Hadford Howell. Representative of the NCSA Board of Directors, Ms. Chantal Evening, and respective members of the Board of Management of the NCSA. Manager of the National Council on Substance Abuse, Mrs. Betty Hunt. Deputy Manager of the NCSA, Mr. Troy Wickham. Research Coordinator of the Findings and Research and Information Officer at the NCSA, Mrs. Laura Foster. Staff of the National Council on Substance Abuse. Respective permanent secretaries, heads of departments, representatives of ministries of government, members of the treatment and rehabilitation sector, specially invited guests, members of the media, ladies and gentlemen. Good afternoon. I'm your Master of Ceremonies for this evening's dissemination of findings on the barriers to substance abuse treatment in Barbados, factors hindering women's use of treatment services. Without further ado, however, it is indeed a pleasure to welcome representative of the NCSA Board of Directors, Ms. Chantal Evening, who will now deliver the official welcome. Ms. Evening.
Protocol having been established, good evening, everyone. Thank you for being here. So on behalf of our chairman, Mr. Hadford Howell, and fellow directors of the Board of Management of the NCSA, it is a privilege to welcome you all to the National Council on Substance Abuse. Today, the NCSA will disseminate the key findings of their report, Barriers to Substance Abuse Treatment in Barbados, Factors Hindering Women's Use of Treatment Services. Now, internationally, research in many different fields consistently identifies the unique challenges faced by women. In my own postgraduate research on the assimilation of highly skilled refugees into the workforce of Scotland, I discovered that while professional assimilation was difficult across the board, it was even harder for women who had all of the challenges males did, and additionally, some unique gender-specific challenges, which included things as simple as the unavailability of suitable childcare options. Similarly, the research of focus today highlights the challenges faced by women who need to access drug treatment services. It looks at how their challenges differ significantly from those faced by their male counterparts. Some of these challenges include the lack of availability and the lack of access to treatment services, specifically catering to women, the lack of social and healthcare services to address the specific needs of women in treatment, legal barriers within the criminal justice system, stigma, gender-based violence, harassment from male and female family members, and ostracism within the workplace. Now, upon further investigation, it becomes evident that even when females with drug use disorders seek treatment, the fallout or the negative impact they experience is far greater than that experienced by males. Given traditional roles of mother and caregivers and nurturers in the family and in the community, women often deny themselves the opportunity to receive treatment, rehabilitation, and the support that they need. Firstly, women fear the permanence of labels such as substance abuser or drug addict and the associated stigma. They also fear being looked upon as worthless people who let down the whole family. Secondly, decisions may be taken not to access outpatient residential treatment programs because they simply don't want to be separated from their children or leave them in the care of the other parent or a relative or close friends. Furthermore, separation of women from their children may be societally perceived as negligence, selfishness, irresponsibility, or a refusal to undertake the maternal duties. As key stakeholders in the drug demand reduction and prevention, today's dissemination of findings will provide us with current information on the extent of the problem locally, as well as provide recommendations to address gaps and enhance the quality of drug treatment services. It is envisaged that these findings will help to inform policy which aims to eliminate barriers in delivery to treatment services in Barbados, be a catalyst for development and enhancement of treatment services specifically for women, and effect meaningful change in the provision of treatment services for women locally. Thank you to all who have attended today, and we want to especially extend commendations to Mrs. Laura Foster and the NCSA Research Department for their timely conduct of this study. Thank you, Laura. Thanks also to our public health partners, treatment and rehabilitation providers, collaborators, and members of the media for your ongoing support. Together, we can work to eliminate the factors hindering women's use of treatment services in Barbados. Thank you and welcome.
Thank you for that warm welcome, Ms. Evelyn. You certainly set the tone for today's proceedings. And certainly we are most proud of our minister, and he always is at the vanguard of new developments, today being no exception. In this regard, we are certainly privileged to have him here with us yet again, as he delivers key remarks in relation to the barriers to substance abuse treatment in Barbados, factors hindering women's use of treatment services. Without further ado, kindly join me as we welcome our Minister of Home Affairs and Information, the Honorable Wilfred Abrams.
Can I close this, or I can cat spread everybody? Just rest on the ground. They always say as a politician to leave an impression. When you go somewhere, make sure they know that you were there. You can always start by rearranging things to suit your own purposes. Good afternoon, everybody. I want to thank you for that very warm welcome, and welcoming your minister. There's a specific place in my heart for the National Council on Substance Abuse. And a lot of that has to do with the fact that if I left it only to the National Council on Substance Abuse, I'd do nothing else in my ministry other than things related to the National Council on Substance Abuse. And that is a good thing, because it means that the council and the board is working exceedingly hard in terms of answering questions and providing solutions, providing empirical evidence, and doing studies that help us to better understand substance abuse in Barbados and the factors that contribute to it and the treatment options available in Barbados. In particular, when I was given the results to read in relation to this particular study that we're about to have be appraised of, it struck me on a personal level. The very, very first person that I identified or became familiar with as being somebody who was not mad, but somebody who had a substance abuse problem, was a woman. It was a woman. And people spoke in hushed tones about her. Nobody accepted that she had a problem. People just pretended that what was happening in front of them didn't actually exist and wasn't actually happening. And that pretty much typifies, for most part, the response we've had to women in the substance abuse arena. When we think of substance abusers, by default, the vast majority of us think of men. And by default, we think of young men. So when we look at detection and treatment options, there's a natural bias in our investigation and our searching for answers to treat the patient, the prejudicial patient in our mind, who happens to be that young, poor, black man in Barbados. So what then happens? Things are skewed and persons get left out. Persons get left out, policies are made, treatments are designed that don't necessarily capture all and leave out an important segment. So I am very touched and very proud of the National Council on Substance Abuse for drilling down and focusing on a problem in Barbados, for that sector that is largely forgotten or ignored or blocked off behind the curtain, because we don't want to accept in Barbados that we do have a problem with women abusing substance as well. So, good afternoon to you all. The other thing I want to do is I want to acknowledge my assistant, Nadia. Nadia's brilliant, right? She's brilliant. And I'll tell you why. So I normally try to limit my addresses to 4 pages, no more than 4. If it can be said in 4 pages, then we schedule it for 2 sessions, right? 4 pages. So having narrowed this down to 4 pages, I asked Nadia just to ensure that it was printed, because the last time I was here, we had the issue with the Surface Pro, with the device. I don't want Microsoft to sue me. So Nadia printed, and Nadia, in concession with the fact that I am well past a half century, managed in what was 4 pages on my Surface Pro, ended up being how many, 6 pages of particularly large font, which she said to me, "You can now do this without your glasses." Nadia, next time aim for 8 pages, because I still need the glasses. So, on to the meat of the matter. I am particularly heartened that, while I've been told there have been many international studies which have examined the barriers to treatment for women, this is the first of its kind to be conducted in this region. So the NCSA is once again a pioneer. And formally, I want to take the opportunity to publicly congratulate all at the NCSA for its efforts. And I'm also going to urge you, I don't just believe in Barbados, I believe in the Caribbean as our neighborhood. So I urge you to don't keep these things to yourself, but to lend your expertise to our other regional partners who might be interested in conducting similar research, because I have no doubt that what obtains here, chances are, is replicated across the Caribbean. The release of these findings comes at a time when there's a global concern for, but thankfully also a renewed emphasis on treatment for women who struggle with substance addiction. The American Addiction Centers reported that in 2022, that over the past year, substance abuse has spiked in the US and globally, and that this change is due largely to the pandemic and its rippling social and economic effects. Citing alarming statistics, the Journal of the American Medical Association underscored that this is only a snapshot of a larger trend, as substance rates among women has steadily increased over the last decade. That article points out that even in the face of this increase, it is difficult to persuade women to seek addiction treatment due to a variety of reasons. And this is something that we've also seen in Barbados. The vast majority of persons, every time we do the Barden study, every time we do the results and the numbers, the vast majority of persons seeking treatment or receiving treatment are actually men. So it is therefore not surprising that the Barbados Drug Information Network, Barden, and their reports have consistently shown that the number of women seeking treatment in Barbados is disproportionately, not just lower, but disproportionately lower than the number of men seeking treatment. Some of us may not be aware it is not as straightforward for women to access treatment as it appears for men, as women typically face a number of treatment barriers which are often related to their specific roles and responsibilities, as well as societal norms and expectations regarding women. These reduce the likelihood that they will seek the help that they so desperately need. Women in Barbados and generally have long played a central role as caregivers, educators, and valuable members of the workforce, and they're often considered the backbone of society. This is particularly the case in Barbados, which has traditionally been matrifocal. If we even think of the structure of Barbados now, our president is a woman, our prime minister is a woman, our deputy prime minister is a woman, our DPP is a woman. About half of our judges are women. Women occupy position. The head of NCSA is a woman. All right, Betty. Okay, all right. But we're typically seeing that Barbados is one of those places that, quite frankly, women seize the opportunities presented. So we are accustomed to seeing women in positions of success. Now, with that comes the other issue. A paper published by the United Nations Office on Drugs and Crime in Vienna informs that more often than men, women have been introduced to substances and continue to use substances with their spouses or partners, who may also be physically or sexually abusive. With little emotional support or financial resources to pay for treatment, childcare, or transportation, women find it difficult to enter and remain in treatment. Also, we have to factor that in many instances, with women in Barbados being the main breadwinners and child rearers within families, that when it comes to a decision about entering a treatment facility, except that there are adequate accommodations for the children and any other family members who rely on them solely for care, such as older parents, as much as they want to access it, residential care becomes problematic. So while a woman may go and be diagnosed, and the treatment options are there, and one of those treatment options to break that habit is residential care, a woman more likely than not will choose her family and her obligations to her family over herself, forego her issues and her treatment to protect and be there for her family, although the problem that she's experiencing and the substance abuse problem may not in her mind actually inhibit or be a barrier to her being able to take care of her family. Her maternal instinct says, I cannot be away from my family, I cannot be away from my children, and this is a problem that we have to acknowledge and find a way to overcome. And we also know that our females are so essential to ensuring a country's stability, progress, and long-term development. So we should welcome any movement towards addressing barriers which prevent them from seeking treatment. It is therefore imperative that we craft relevant and appropriate strategies to combat the scourge of substance abuse and addiction. In this regard, drug-related research is an essential tool which can and should be used to guide policy making and programming, as it provides an understanding of the drug situation and hence forms the foundation of an evidence-based national response. I am hopeful that today's presentation will open the door for us as a nation, for us as the NCSA, to address the barriers head-on with a view to increasing treatment uptake among women. In so doing, we'll be better placed to facilitate recovery among members of this valuable sector and population, and by extension, mitigate the adverse effects associated with addiction at both the micro and macro levels. For these reasons, I encourage treatment providers, policymakers, and other stakeholders present here today, and those of you online, to take note of the findings and look for ways that you can use them to inform the work you do with women. Allow me to end on this point. In the area particularly of substance abuse, it is a lot easier for a man to put his hand up and say, I need help, and do what is necessary to get help. Because we've stereotyped the addict in our mind to being the man, we are accommodating of that plea for help without the judgment that a woman in the same position is going to get. Recently I was somewhere and there were a lot of drinks happening there. And there were some drunk people. I was there in the protest. And, you know, we saw the fellas getting drunk. I cannot even remember which of the men got drunk. I do remember the one woman who was clearly drunk. I remember because I stopped. I looked, everybody stopped, everybody looked. And everybody talked about her. And nobody stepped in to tell her, stop and respect yourself. It is exactly that reason and that perception and that bias that we perpetuate that prevents women in Barbados from getting the assistance that they need. Because of the position that we hold women in Barbados, because of their role in society, because of their roles in families, when we do not recognize what is going on and provide them with the help that they need, we are not just hurting them. We are hurting them and everybody else that depends on them. If the position of the matriarch is one for a child that is colored or stained or tarnished or broken, then that child has nothing to hold on to. In Barbados, we never think single parent and think the man. We never think single parent and think the man. Most single parent households are households that are run and managed by women. So if you're in a two-parent household, that child is benefiting from mother and father. If you're in a one-parent household, chances are that child is benefiting from the mother. So to protect our children and the future of our country, we must address the issues that confront women and the challenges that they have in accessing and making available treatment to assist them. This, I don't want to prejudice anything that's happened before, but I think this is perhaps the most important study that the NCSA has done since I've been associated with the NCSA. It is not just a theoretical study. It is not just a paper study. It is not just something else that we publish, we report on, and we file away. I want this study now to drive some policy on behalf of the NCSA. I want this to be the catalyst for action in assisting that demographic that most needs our assistance, but finds themselves least likely to ask for it, to seek it out, or to benefit from it. Having said all of that, I'm eagerly looking forward to the presentation, and I'm sure that all attendees will share a similar sentiment. So without much further ado, I now turn the floor back over to our eminent MC, a lady of many, many words and all of them eloquent. And I wish you a good and productive session. Thank you very much.
Thank you, Honorable Minister. And certainly we will heed that call to be the catalyst for change through this research. At this time, the piece de résistance, the presentation of the key findings from the Barriers to Treatment report. And our learned colleague, Research and Information Officer here at the National Council on Substance Abuse, Mrs. Laura Foster, will now present on those findings. Ms. Foster.
My name is, good evening everyone again, sorry. As Paulavette said, my name is Laura Foster, and this evening I'll be presenting the findings from this study for you. To begin with, I'll give you a bit of background about the study, why it is we thought it would be important. Then I'll touch on our methodology. And once I've given you a little understanding of how we did what we did, then we will start to look at the findings, and I'll discuss what we found, why we may have found them, and why they are important. I'll also give some recommendations based on the findings, and then I'll begin to wrap up by looking at future research and basically what our takeaways from this study should be. So why exactly did we conduct the study? And you would have heard the minister say that for many years our Barden reports kept showing that there was this disproportionate number of women seeking treatment compared to men. And after a few years, we started to realize, well, this was a definite trend. So we wanted to know why. And naturally, our first port of call was the treatment providers. And when we went to them, they told us that based on their experience, that the number of women that we were seeing coming into treatment was not a true reflection of the number who actually need treatment. And they suggested that women do not present for treatment for various barriers beyond their control. One that kept coming up was one that you heard mentioned earlier, and that was the issue of childcare. And specifically the fact that they do not have persons who can help take care of their children while they're in treatment. So having heard all of this, we decided that we wanted to dig deeper. We wanted to know exactly what was going on. What really are the barriers for women in Barbados? And we thought that this would be particularly useful for our policymakers as well as for practitioners within the field. So that said, we made the decision to conduct this study. Now, why should we be concerned with the fact that women are underrepresented in treatment? The international literature shows us that while women use drugs less frequently than men, they actually develop substance use problems more quickly, and when they do, their disorders tend to be more severe. Women also tend to experience more severe consequences as a result of their drug use. So we're talking about things like medical problems, as well as difficulties functioning in their day-to-day lives. In order to prevent the progression of substance use disorders and mitigate the associated negative effects, treatment services must be accessible and utilized by this population. The international literature confirms what our treatment providers were telling us, that women do in fact face a range of treatment barriers, and these need to be addressed at the policy and program levels. But of course, the first step has to be in identifying the barriers. You would have heard the minister say that there isn't much data on this in the region. There have been a lot of international studies, but the fact is we can't be sure that what has been found internationally is really applicable to our cultural reality. So we definitely saw a need to conduct this study. Now, all of that said, we can say that this study is important because, one, it satisfies that need for local data on the topic, but also because the findings, and this is more important, the findings can be used to craft relevant policies and programs. As this was an exploratory study, our research objectives were relatively straightforward. We wanted to identify and describe the barriers to substance abuse treatment for women in Barbados as they're seen by both the treatment providers as well as the treatment clients. And we wanted to identify and describe possible solutions which may reduce the impact of the identified barriers. Now you can see here from this slide that we reference a number of key terms, namely substance abuse treatment barriers, as well as internal and external barriers. And for the purposes of this research, a substance abuse treatment barrier was considered to be anything that serves as an obstacle to an individual receiving care or treatment for substance abuse or addiction. So anything that prevents women from presenting for treatment in general, anything that stops them from returning to start treatment after their initial assessment, things that that cause them to miss sessions and interrupt the progress of their treatment. Also, things that cause women to drop out of treatment without completing the program. Internal barriers in particular are things that are subjective to the individual, their thoughts, their beliefs, their perceptions. The external barriers, on the other hand, are things outside of their control. So our culture, our social environment, characteristics of treatment programs, those sorts of things. Now, a little bit about our methodology. We used a qualitative approach, as again, we were exploring, so we wanted to be able to dig deeper. We relied on individual interviews with treatment providers, as well as a focus group with treatment clients. We asked the treatment centers to identify appropriate clients as well as providers to take part in the study. And they did this using our inclusion and exclusion criteria. And we were very specific about who we wanted in our study and who should not be included, because we wanted to protect the integrity of our data. In terms of our data collection instruments, we used interview schedules that were specially designed for this study. And we crafted our questions using the international literature as a guide, and we made sure that the questions were designed to obtain participants' views on the topic. In terms of our participants, we interviewed 4 treatment providers. 3 were from outpatient facilities and 1 was from a residential facility. They range in age from approximately 35 to 55 years, and they were all actively involved in treatment delivery. Interestingly, they all ended up being female, but this was not intentional. With regards to our treatment clients, they were all drawn from the island's lone residential treatment program for women. We had both young and middle-aged female adults taking part. Some were mothers, while others were not. And some reported being employed at the time of their treatment admission, while others were unemployed. For our data analysis, we relied on the transcripts of the interview sessions. These were reviewed using a combination of inductive and deductive analysis. And this simply means that we looked for commonalities within the responses that were received from the participants, and we grouped these according to what we call themes. We then took these themes and subdivided them into those 2 broad categories I told you about, so those internal and external barriers. Now, before we look at the findings, I want to address a number of the study's limitations up front. Given our reliance on a qualitative methodology and a small, convenient sample, it's quite likely that our participants were not truly representative of the wider population. So this, of course, will have implications for the generalizability of our findings. I also mentioned that the participating treatment clients were all drawn from residential treatment. So for this reason, there is a noticeable absence of data from outpatient clients, and this was unavoidable. The study was actually designed to include survey responses from outpatient clients. However, there were insufficient females in outpatient treatment during the time that we were collecting our data. So again, this is a reflection of the fact that women just aren't coming into treatment. And we took various steps to try to include them. So we implemented a number of data collection extensions. We also sought to find alternate sources, so other women who might be able to give us that data. But everything proved futile. So ultimately, we had to bring it to an end and just work with what we had, which was our interview data. The data collection extensions that I mentioned had a trickle-down effect, because with each extension, the interview data continued to age. So in fact, by the time we reached the end of the report writing process, our interview data was about 2 to 2.5 years old. So this could raise questions about the relevance of the information today. But it should be noted that in order to ensure the continued relevance of the data, checks were made when we were writing the report to ensure that no significant changes had taken place. Another limitation lies in the fact that only clients currently seeking treatment were included in the study, and those who need treatment but have not yet accessed it may have different barriers to those who actually made it into treatment. Likewise, their recommendations may also differ. But the reality is that this population is hidden. So we weren't able to include them in the study because we couldn't necessarily find them to include them. Lastly, the reliance on treatment centers to recruit participants may have introduced a level of selection bias, particularly in the selection of treatment clients. They may have recruited persons who are more articulate, who are doing well in treatment, and therefore have more positive views of treatment and the whole treatment process. As such, this may have influenced their responses. Now, all in all, it should be noted that despite these limitations, the findings of the study are actually still very similar to those uncovered by previous international studies, so those that had the larger samples and qualitative data, etc. So we can still take comfort in that fact as we go forward this evening. Now, all of that said, let's actually look at what we found. And I'm going to start with some information about the women who seek treatment in Barbados, because I thought that this would give us a great backdrop against which to interpret the barrier findings as we go forward. And that said, we asked the treatment providers to tell us who are the women that seek treatment in your centres. And we did note that there is a slight variation as we move from centre to centre. So in terms of age, we found that the NCSA tends to treat women who are in the young adult years, so their 20s and their 30s, whereas the Centre for Counselling Addiction Support Alternatives will tend to treat women who are more middle-aged, so 40 to 45, that kind of age group. The drug rehabilitation unit at the psychiatric hospital, they tend to see persons in middle to late adulthood, so between 40s and 70s. And at Marina House, the local residential facility, the representative there reported they treat women across the lifespan. So anybody 18 and over, that's who they will come into contact with. With regards to dependents, like our participants, the women seeking treatment have children while others do not. So some of them, you'll find some mothers, some who are not mothers, some have also sought treatment while they are pregnant. For employment, the representative from Marina House noted that they treat all types of persons. So they will see professionals as well as the unemployed and even homeless persons. At the outpatient centres, women are more likely to be unemployed or in the low income bracket. And in terms of drug of choice, there was a great similarity across the centres with this one. Regardless of the centre, it was reported that alcohol and marijuana tend to be the drugs of choice for women in Barbados. We also sought to understand the reasons why women begin to use drugs. And for this, we went to the treatment clients who were taking part in the study. And they indicated that women begin using drugs for a variety of reasons. Some may use them as a means of coping with violence that they have experienced during their lifetime, so bullying and domestic violence, that sort of thing. Others use it to cope with the fact that they have to rely on prostitution as a means of income. As one woman put it, to bring out your esteem. Some use drugs to escape from the stress of daily living or strong emotions, in which case it is used as a mask or a suppressant, they said. The women suggested that this is particularly true for women who may not be willing to talk about their problems with anyone, even with counselors. And lastly, some women just use drugs for fun. So let's look at the reason why we're here. And as I said before, we divided the barriers into two broad categories, external and internal. And this slide depicts the fact that the external barriers were far more numerous than the internal ones. And I'm going to start with the external barriers. I've set these out in the apparent order of significance based on the discussions with both the women in treatment and the treatment providers. And first and foremost, we have the issue of childcare and the related matter of child welfare concerns. Then there's stigma and lack of family support, unmet basic needs, absence of workplace drug policies, having a drug using or drug selling partner, and characteristics of treatment programs and facilities. It's not surprising that the issues of child care and child welfare are the most dominant. This is consistent with the international literature as well as the anecdotal reports from the treatment providers that served as the foundation for this study. This may be related in part, as you heard the minister speak about, our matrifocal nature of our society. Women have traditionally been the main breadwinners, the main child rearers, as he said in Barbados, and their domestic responsibilities can understandably make it difficult for them to seek treatment, impractical almost, particularly residential treatment. This is compounded by the fact that many women with substance use disorders do not have anyone who can help with childcare in their absence. Their relationships with their families have either been severed or in a bad state due to their drug use. They may not know who the fathers of their children are, or even if they do, the fathers may not be involved in their children's lives. And as such, some may have to rely on the state to take care of the children in their absence. And this can introduce concerns about being able to regain custody once they leave treatment. Those who are able to identify a viable childcare option, be it someone they know or the state, often have concerns about the safety and welfare of their children in their absence. And it was noted by the women that this can be due to the fact that many of them have experienced abuse or violence of some kind during their lifetime. And in the words of one woman, women ain't coming in no safe haven and left in their kids. For those who do enter treatment, the fears and concerns about their children's welfare and safety can be so great that they're not able to concentrate on the treatment sessions when they're there. And in extreme cases, they may even drop out. Similarly, those in outpatient treatment also have challenges with childcare. They too may not have anyone to watch the children while they're at a session, and they do not want to leave the children alone because they're afraid of being arrested or having the children taken away from them. Those who do take the chance and leave the children and come to a session often can't focus because of the very same fears. Stigma was another significant barrier identified. This too aligns with the international literature, which shows that stigma and by extension discrimination frequently prevent people from seeking treatment. And this is a universal finding. It's not limited to any particular geographical area or culture. Of particular concern is the fear of being judged and discriminated against. Stigma can be a barrier for both men and women, but it is particularly impactful for women because female substance use is more highly stigmatized, particularly drug use by mothers. This was underscored by one treatment provider who stated, "An alcoholic father is different to an alcoholic mother. They might call them alcoholics, but they may add on another bad word to it because you're a female." As such, some women choose not to seek treatment in an attempt to avoid being labeled by society. It was also revealed that addiction stigma is so powerful that some clients are hesitant to seek treatment at facilities that have addiction or substance abuse in the name. Related to stigma is the issue of stereotypes. We may not like to admit it, but we all have these preconceived images in our minds of what an addict looks like, who they are. But the reality is that not all addicts look the same. So even though these images are transmitted through our culture, they persist in the media, and we can't let them go. They're very much there, but many addicts hold good jobs, they live in lovely houses, but it's those same stereotypes that actually will keep women out of treatment. One woman actually said that she was in denial for a long time because people have this picture of who is an addict, and she did too. And according to her, she didn't fit the bill. So therefore, she took a long time to realize that she may have had a substance use disorder. There's also the matter of stigma surrounding the psychiatric hospital. Like drug use, mental illness is also highly stigmatized, and multiple participants, both treatment providers and clients, noted that having to go to the psychiatric hospital for assessment or for outpatient treatment can be a deterrent, as women do not want to be labeled as mad or crazy if someone sees them going through the gates of the hospital. Lack of family support. As I mentioned earlier, many women with substance use disorders do not have good relationships with their families. As such, they typically lack a strong family support system. And a strong support system is key to increasing treatment success. In fact, research has shown that persons in active treatment have higher levels of perceived social support on admission when compared to those not in treatment. Similarly, strong social support networks have been associated with longer stays in treatment, better recovery outcomes, and a reduced likelihood of relapse. Where women do have relationships with their families, there can be a lack of support for treatment in general. This can happen when the family is ashamed or may simply not see the benefit of drug treatment. They may think that the individual can just stop on their own, or that going to church partner reduces the likelihood of treatment entry and increases the possibility of dropout and relapse. Likewise, having a partner who sells drugs can also be problematic. It was revealed that some men expect the women to assist them in preparing and selling the drugs, and as such, the women can find it difficult to seek treatment because their family income is dependent on the very same drug that they use. Unmet basic needs. It was suggested that many women with substance use disorders are not working, and therefore they are dependent on others to pay their bills, buy their food, etc. They may be reliant on the same drug-using partner or on family members. And those whose basic needs, such as food and housing, are not met will be less likely to seek treatment because they're focused on getting food and finding somewhere to live, keeping the lights on. And this is further compounded when they have their children, because they'll be struggling to provide these things for the children in an attempt to avoid having them taken away by the state. This revelation is supported here by Maslow's hierarchy of needs, which is represented by the pyramid. Each level of the pyramid represents a set of needs which must be satisfied before the individual can move on to the next level. And all of the needs must be satisfied before an individual can reach their full potential, or in the words of the theory, self-actualize. According to Maslow, needs such as housing and food are the most basic, and they will be the priority for any individual for whom they are not satisfied, and women with substance use disorders are no exception. Compounding factors include additional financial stress and the need to rely on prostitution for financial support, because both of these can lead to continued use as a coping mechanism. Many of the local treatment centers provide assistance to clients, and they do so using their own budgets or by referring clients to relevant social agencies in some cases. However, at present, there are no formalized partnerships between the treatment centers and social agencies, and this can hinder the consistent provision of such support. Instead, there's a reliance on the relationships which treatment personnel have developed with staff in the various agencies. Absence of workplace drug policies. The participants revealed that they were afraid to lose their jobs if anyone at work found out that they had a drug problem. This coincides with NCSA's recent pilot workplace survey, which revealed that 50% of participants were afraid that they would lose their jobs if they admitted to having a substance use problem. The participants indicated that the fear of job loss was made worse by the absence of workplace drug policies. Drug policies enable organizations to effectively respond to the issue of drug use within the workplace, while simultaneously assisting employees with substance use disorders. They set out the procedures to be followed, the available support, and how it can be accessed. As such, the lack of protocols made the women concerned about the possible repercussions if their colleagues or employers found out that they used drugs or had a drug addiction. They also revealed that they know others in their workplaces who have been afraid to come forward because they do not know what is going to happen. In such cases, persons may opt to downplay their addiction and avoid seeking help. Likewise, the lack of protocols can also delay access to treatment in cases where a substance use problem comes to light. One client indicated that she went to her boss to get help, but they had no drug policy in place. That she went to them in January. It took them until August to be able to source potential help for her. And at the time of the focus group, which was at the end of that same year, her workplace still had no drug policy, and she did not know what was going to happen with her job when she left treatment. The negative impact which the absence of drug policies can have on treatment seeking is concerning, as drug use in the workplace can contribute to accidents and injury to self and others on the job. It can lead to increased absenteeism, reduced productivity, poor performance, and increased turnover. So in short, it can be dangerous and costly. Treatment characteristics. Those of concern to the clients differ from those mentioned by the treatment providers. The treatment clients spoke mainly to the restrictions in place within the residential program. They noted that these can make the program feel more like a prison than treatment. And of course, this will be a deterrent for those who hear it described by others who've been in treatment before. It can also lead persons who enter treatment to drop out. The treatment providers spoke more to issues surrounding accessibility, particularly the accessibility of outpatient treatment. In this regard, limited opening hours and the geographical location of the treatment centers can be problematic. Not opening outside of normal working hours can be a hindrance for women who work to attend. Similarly, centers that are off the beaten track and not easily accessible by bus can also be a problem. After all, for someone to utilize a treatment service, they have to be able to access it. Not surprisingly, this finding aligns with international research, which suggests that women are less likely to utilize treatment services which are not easily accessible to them. Also of concern was the lack of inpatient detoxification at the psychiatric hospital. Inpatient detoxification was stopped at the onset of the COVID-19 pandemic and has not yet been reinstated. While outpatient detox is being done and can be successful for specific types of clients, it is not suitable for everyone, and it's associated with higher rates of relapse and dropout due to persons having access to their drugs of choice, not adhering to the detox regimen, and skipping daily appointments. One treatment provider also noted that it can be particularly difficult for persons to experience the withdrawal effects on their own without the support that would typically come from being within a hospital setting. And this in and of itself can make it likely that persons will relapse before the detox is complete. Let's now turn to the internal barriers, and there were only 4 categories identified, and they were generally all of equal significance. The first is denial, also fears, lack of knowledge about treatment services, and co-occurring disorders. Denial was identified as a treatment barrier by both the clients and the providers, and the international literature confirms that denial is one of the main hurdles in treatment and recovery, as it prevents persons from recognizing and acknowledging that they have a substance use problem. It is not unique to women and can affect anyone with a substance use disorder. Quite simply, persons who do not accept that they have a problem will be less likely to seek treatment, even in the face of concern from their family and friends. It was noted that denial may be stronger in cases where women are court-ordered to attend treatment. As such, they do not feel that they have a choice or a say in the matter. One woman spoke about the day that the judge ordered her to go to treatment. She said that the judge told her she was to go as soon as she left court, and she asked the judge for some time to make some arrangements, but the judge was adamant she was to go right after leaving court, and this made her angry. So, on leaving court, instead of going to treatment, she went and used. Denial is complex, and it's not simply about being blind to the negative consequences associated with drug use. It often serves an important function for the individual. So, for example, it may allow them to continue to use in order to avoid the unpleasant effects of withdrawal. It can also allow them to continue to use as a coping mechanism for overwhelming emotions or situations that they're just not ready to deal with. But regardless of the function which denial is playing for the person, what we do know is that those who are in denial typically lack the motivation to change and are therefore less likely to seek treatment. Therefore, it's important that steps be taken to encourage help seeking among those in denial, and especially trained professionals can help in this regard. Fears. The most dominant fears were related to the safety and well-being of the women's children, job loss, and stigmatization, and I would have discussed all of these already. So I'm going to move on to some of the others that were mentioned, one of which was fear of the treatment process. Specifically not knowing what to expect and a fear that it would not work. It was said, I am not going to go somewhere that I'm not sure if it will work. The fear of having to face past hurts during the treatment process was also identified. Women are scared about how they will feel when old wounds are reopened, and some prefer to avoid this at all costs. Fears surrounding the possibility of having contracted a communicable disease during their active use and only finding out about it on treatment entry can also be a deterrent for some women. Others, on the other hand, who have already been diagnosed may have a sense of hopelessness, and they just concede, well, they're dead already, so why bother to seek help? Lack of knowledge about the available treatment services. Both the clients and the providers highlighted the fact that some women do not know what treatment services are available on island, and this can prevent them from being able to seek treatment. This corresponds with the international literature, which shows that even when persons acknowledge that they have a problem and they want to change, not knowing where to go for help can be a significant deterrent. It was also pointed out that the persons women turn to for help may also know what services exist. These include medical practitioners. When persons do not know where to go, or when doctors do not know where to refer their patients, you will get obvious delays in access to treatment. And this is critical, because you may just miss that window when persons want to get help. And by the time the resources are identified, they may have changed their mind and are no longer ready for treatment. Now we're to the last barrier, namely co-occurring disorders. Mental illnesses commonly co-occur with substance use disorders both here and abroad. In fact, the 2021 Barden report showed that between 21 and 33% of persons admitted to the psychiatric hospital between 2018 and 2021 had a co-occurring disorder which included a substance use disorder. Co-occurring disorders are well-documented treatment barriers within the literature, as well as factors which can reduce the success rates for persons in treatment because they pose diagnostic challenges and they also complicate the treatment process. Internationally, large prevalence treatment deficits have been noted. And one national study conducted in the United States showed that 9.1% of the participants with co-occurring disorders received both mental health and substance use treatment, 34.5% received mental health care only, 3.9% received substance use treatment only, and 52.5% received neither. In this study, the issue of co-occurring disorders was mainly highlighted by the treatment providers. However, one client did note the fact that she also has bipolar disorder. So that underscored the fact that co-occurring disorders are very real and they must be considered when treatment planning. It is important that persons with co-occurring disorders have both their mental illnesses as well as their drug use disorders treated, because failure to do so is associated with poorer prognosis. So now it's time for some solutions. And what I will present here are the key recommendations. There are others, and for the full list, I invite you to view the report, which will be available on our website. To address the issue of child care and child welfare concerns, given the significance of these as voiced by the participants, it is recommended that child care be provided as a wraparound or a support service for women in treatment. If women can rest assured that their children will be safe and well cared for while they are in treatment, they're more likely to come. They're also more likely to stay and complete the process. With regards to stigma, research has shown that this is often the result of a lack of understanding or fear brought about by misinformation. And also the view that addiction is a moral failing rather than a chronic relapsing disorder which can be treated. That said, target interventions which seek to raise persons' knowledge about addiction through information and direct experience have proven useful in reducing the stigma and marginalization associated with substance use disorders. As such, we are calling for public education and are specifically recommending a widespread campaign that seeks to raise awareness about addiction and treatment. This campaign can include traditional and social media, public lectures, workshops, and the like. And the information shared should speak to the nature and causes of addiction, its impact, and those who may be affected. This can also be buttressed by the hosting of a National Recovery Week or month each year. The idea is to highlight the issues of addiction, treatment, and recovery on a continuous basis. The language that we use can be very powerful, and as such, we should follow the international guidelines which promote the use of language that reduces negative bias when discussing addiction. So for example, using the term person with an alcohol use disorder instead of alcoholic or drunk. Using person-first language such as this shows that the person with a substance use disorder has an illness, rather than portraying them as being the problem. This shift in language will be particularly useful among prevention and treatment professionals, as well as healthcare and social workers, and it can be achieved through sensitization workshops. It is also recommended that the community psychiatric clinics be used to address the hesitation which persons have about the psychiatric hospital. These clinics operate within the island's polyclinic system and currently also conduct the assessments and make the necessary referrals for residential treatment. However, this is not widely known, and the service is limited by the fact that the community psychiatric clinics are held on select days at each polyclinic. Therefore, it is recommended that 1, the assessment and referral services be promoted to the general public. 2, the frequency with which these psychiatric clinics are held be increased. And 3, add outpatient drug counseling sessions to the suite of services which are offered. With regards to the issues surrounding social support, We know that this is important for treatment entry and success, but the fact is that some women just don't have that support system. So what can we do about it? Well, it's recommended that the possibility of peer support groups as well as interventions to foster family support be explored. Also, treatment programs should encourage active involvement in 12-step mutual aid programs as an adjunct to a structured drug treatment program. While many of the local treatment centers promote attendance at 12-step programs, research has shown that active participation is a better predictor of improved treatment outcomes than mere attendance. And active participation includes speaking at meetings, working on one or more of the 12 steps, having a sponsor, and even just performing duties at meetings, so things like making coffee or helping arrange the refreshments. The importance of ensuring that women's basic needs are met is acknowledged, and for that reason, it is recommended that a coordinated national support mechanism be established. This mechanism should, by design, create the needed formalized partnerships and enhance the provision of assistance by facilitating access to a wider range of services and preventing the wastage that can occur when persons move from agency to agency seeking similar types of assistance. For the mechanism to function effectively, it is recommended that it have a point person who is responsible for creating and maintaining a register of participating governmental and non-governmental agencies, as well as the forms of assistance that they're willing to offer. There should also be a formal process for referral and follow-up through that point person, as well as a centralized database which details the assistance provided to specific individuals. The provision of employment assistance and equipping clients with the knowledge and skills needed to obtain or sustain employment is yet another recommendation that has the potential to be particularly impactful. As research has shown that persons who are employed are less likely to relapse and be in conflict with the law. They also tend to have a higher abstinence rate, improve quality of life, and are more likely to successfully reintegrate into society. To address the absence of workplace drug policies, it is recommended that there be a national push for the establishment of such policies. And this can start with a campaign led by the NCSA due to the Council's past experience helping organizations develop their drug policies. The campaign should include carefully crafted marketing messages and workshops designed to raise awareness about workplace drug policies, including their purpose, their benefits, and their general content. The NCSA should also expand their policy drafting services to the wider business community in Barbados and continue its workplace drug education initiatives to raise awareness about drug use and related issues, as well as promote a culture of non-judgment within workplaces. With regards to the matter of detoxification, specifically the use of outpatient detoxification not being suitable for all, it is recommended that inpatient detoxification be reintroduced and used with clients for whom outpatient detox is contraindicated. Careful screening will be needed to determine who these individuals are. Additionally, efforts must be made to ensure that the necessary supports are put in place for those undergoing outpatient detox to successfully complete the process. For issues related to denial, it is recommended that the primary care setting be used to increase motivation to change. Primary care physicians are uniquely placed to identify and intervene with patients who may not otherwise be willing or see the need to change their behavior, as they typically have an ongoing relationship and an established rapport with these individuals that will allow them to express a genuine concern and thus allow the patient to be more willing to accept their intervention. That said, the use of specialized techniques such as screening, brief interventions, and motivational interviewing should be introduced within the primary care setting, as they can help identify patients who may need treatment and encourage them to seek help. In this regard, the necessary training should be provided to the physicians to ensure that they are equipped to use the techniques. To address the public's lack of knowledge about treatment options, information on these can be included in the previously mentioned public education campaign. And additional efforts can include sharing information via health fairs, seminars, and advertisements. Online marketing strategies such as search engine optimization and pay-per-click advertising can improve persons' ability to find treatment options via online searches. Various initiatives can also be used to educate the medical fraternity about treatment options, and these include presentations at continuing medical education conferences, workshops, and even sending pamphlets to doctors' offices, so something as simple as that. Given the negative impact which co-occurring disorders have on treatment and the individual, it is imperative that persons receive the necessary care for all mental health and substance use disorders they may have. And proper identification and diagnosis is the critical first step. As such, it is recommended that persons presenting for mental health treatment be screened for substance use disorders and vice versa. This is in keeping with the no wrong door policy of the Substance Abuse and Mental Health Services Administration, or SAMHSA. According to this approach, persons with co-occurring disorders can enter the treatment system through a wide range of avenues, and proactive measures must be taken to ensure that they are identified, assessed, and treated regardless of their point of entry. Treatment processes are also important. As such, it is recommended that integrated treatment be implemented within our mental health and drug treatment facilities. Integrated approaches involve the simultaneous treatment of mental health and substance use disorders, as opposed to previous approaches which saw them being treated either in parallel or consecutively. And integrated approaches have since been shown to be the most efficacious. While offering integrated treatment in one location is ideal, it's not always practical due to resource constraints. So in such cases, it is recommended that partnerships be established between the various facilities to allow for that cohesive approach to assessment and diagnosis, as well as treatment planning and case management. I'm now going to start to wrap up, and I think we can all agree that this study certainly provides useful local data on the topic. And in so doing, it also serves as a springboard for future research. As such, it is recommended that the topic be investigated using a larger, more representative sample to facilitate extrapolation to our wider target population. A similar study should also be conducted among persons who are not yet in treatment, because they may have additional barriers which would benefit from intervention at the policy level. Likewise, a study which includes men should be conducted to determine if their barriers to treatment are systematically different. And lastly, consideration can be given to investigating the relationship between unmet needs and the motivation for treatment, using Maslow's hierarchy of needs as a theoretical foundation. This study's use of the theory was based on reason, but research of this nature could reveal a potential pathway for treatment for persons who have not yet sought help, and in so doing could provide empirical support for initiatives designed to help meet their basic needs. In conclusion, we saw that women face many barriers which can prevent them from seeking or completing treatment. While some may be related to their roles and experiences as women, others are not gender specific and can also affect men. Most of the identified barriers were external in nature, which means that they can be more easily addressed through policy and programming initiatives such as those proposed. And while the internal barriers may pose a greater challenge, initial efforts can also be guided by the proposed recommendations. Overall, this study's findings and recommendations can serve as a useful guide for policy and program initiatives designed to increase treatment uptake and retention among women on island. And this will be critical, as treatment must be utilized by a large percentage of those in need of the services if it is to have a substantial public health impact. And that brings me to the end of my presentation. So at this point, I'm going to hand you back over to Paula Vett so that we can continue with the program.
and gentlemen, let's certainly give Ms. Foster a round of applause for that comprehensive and instructive presentation. Minister, we had invited your comments after the presentation. We would love to hear a snippet of what you have to say, certainly.
I keep saying that I continue to be impressed by the work of the NCSA. And Laura, so in my mind, you're my little hamster, right? You're that person that's constantly running on the wheel. I don't know where you find the ability and the time to keep doing these things and generating this much needed information that allows us to do a deep dive into the main course and design proper strategies. But I want to commend you and compliment you, Laura, for your dedication to the cause, your hard work and your diligence. And I will say, every time I come here, every time I have to speak again after having heard one of the reports, my constant refrain is do what you have to do, right? This has taken the cork off. We've opened the book, and there are a lot more pages to go, right? And yes, I do think we can benefit from a more in-depth study. In designing treatment options, it's always good to have an idea, but the more persons that you interview and the more empirical evidence you have, the better your ability to design and the better the basis for your recommendations. So, as I said, do what you have to do. It would help us a lot as well if, and as I said, I started by saying I'm glad that we've done this research on women because of the particular issue that we face and because of the particular perception and bias where women are concerned in Barbados. But it would be interesting to know what barriers there are for men as well, right? I think that most of the studies show that men are in the majority. We accept that. Women are underreported, right? But men are in the majority. And as a government, it'll be useful for us to know what hurdles we need to overcome, what things we need to put in place to make the seeking of treatment something that's admirable and lauded, as opposed to something that is derided and is humiliating to the person who's seeking treatment. If we use it as an example, I am amazed every time I go to football and I see the amount of young men who smoke. I actually have difficulty believing when I go to watch football that weed is illegal in Barbados, right? And you can talk to the cows come home, right? Those fellas come off the field and go and smoke some weed. They're smoking before they go out, which is why a lot of them can't run, right? I had this discussion with Troy at a football match as we watched a certain team wheezing out while playing UE, and the UE students were running. No, he wasn't playing football. No, he was in the stand. And you see the difference between the BDF team where a person in the BDF are drug tested, right? Or the UE team where a lot of them, you see the difference between those and village teams. And we can talk about social responsibility, and we can talk about family, and we can talk about drug addiction. But unless the message is crafted in a way that makes sense to the persons who are receiving it, we're wasting time. They need to understand if you actually want to be a professional footballer, you can get tested for drugs. So decide whether you want to smoke weed or decide whether you want to be an athlete, right? All of the youngsters in school who want to be Usain Bolt or I almost said Sha'Carri. I meant Sharika. Or Shelley Ann Fraser Price, right? They need to understand that their behavior and what they get into now is going to color their ability to develop in their particular fields. So, sorry. I apologize to all who are listening on our line. Let us pick the example closest to home. Sadie Williams, right? Sadie cannot be smoking weed and running the times that she runs. So all who said I went to her school and she was one of us, and if she could do it, I could do it too, then you got to do the things that she's doing and not do the things that she's not doing as well. So I commend you on the information. I commend you in particular. I hate when people present problems or they give me a snapshot and say this is what the issue is, right? And these are the hurdles we have to overcome, but they don't point us in a direction that we should go. Some of your recommendations, I am going to recommend that we act on them even before you go any further, because some of them are no-brainers. We would not have thought of them necessarily before this, but having seen them there, then we can immediately, I saw everybody nodding as you were speaking, right? Because have you ever been somewhere and somebody, like you watch things on TV and you see somebody is now a billionaire because they invented this thing that stores socks. And you say to yourself, but I could have done that. And it makes sense once you've seen it. So a lot of your recommendations make perfect sense to me, and I don't have to wait for you to go much further before we can have the conversation and you tell me the ones that you think we should act on immediately. But to wrap it up, I think this is an impressive body of work. I think it is. I think it's only the beginning. I think that NCSA has been doing a lot of work, but there's also a lot more work to be done. So we need more hamsters and a bigger wheel, right? But Laura, congratulations. NCSA, congratulations. And let us put our heads together and see which ones we can tackle immediately. Thank you.
Thank you, Minister. And certainly, I'm sure your Ms. Adams will be clearing your calendar in short order. Now, today we have been looking at the barriers to substance abuse treatment in Barbados and the factors hindering women's use of treatment services. And NCSA is that special blend of people, of a family. And we are certainly privileged to have today a young lady who has the courage and fortitude to be with us here today. We certainly appreciate and honor you for this. And we are very keen to hear your perspective. So without further ado, I'd like to invite you to share your story and to provide a client's perspective.
Okay, so let me just first introduce one of our really, sorry, I'm very emotional to see you here today. One of our clients, I am Alison, sorry, Betty's telling me to come across, sorry, darling. I'm Alison Gotip, Director of Verdon and Marina House, and I'm so proud today that we have one of our clients who would have gone through the Marina House system, but it's not a system. We are a residential treatment provider located in St. John, and I want to introduce Vicky. So at times I may ask her questions just to prompt us to have that conversation, but I don't have anything to say, but hand over the mic to you, Vicky.
Good evening, everyone.
Good evening.
Okay, my name is Vicky. I was at Marina Hops. I spent a year. For me, the process was amazing. Without Marina, I wouldn't be where I am today. I was drinking for a very long time. I was born in Barbados, but I grew up in St. Lucia. When I came back, after my mom passed away, I went back into drinking very heavily, having just had a little baby. So I couldn't take care of her. I needed the help, but I didn't know where to start. So the drinking got so out of control that during COVID, I ended up on the road, naked as I born. Police held me, brought me into psychiatric. And while I was there, the owner of a gas station I broke into that night came in and he saw me sitting in the room where they had me held. And he looked at me and he said something to me that just clicked. That same time, he said, looking at you right now and looking at you on that camera, you are two different persons. Something is wrong and you need help. Then he left. He told me, you really need to get the help. And I tell him, sure, okay. After he left, one of the nurses came and spoke to me about Marina House, but I never heard about Marina House. So I was asking her, so what exactly was it? She told me, well, it's a place that would help you with your addiction and you can go from there. She asked me, can I call them if you are willing to go? Tell him, sure. At this time, anything is possible. They went. I had spent one more week in psychiatric and Van did come and collect me and I went to Marina. While I was there, for the first couple of weeks, it was a little hesitant because when I was there, only my one was really inside. And I really didn't know what it was about. And then after came, one or two girls came in after. But the most thing that was with me inside there was my daughter, thinking about my daughter. And I'll get the counselors to keep talking to you about, yes, you need the help, yes, you have to, yes, we know you're going to talk about, you're going to worry about your daughter, but right now, worrying about your daughter is not going to help you. Understand? So I got another counselor, her name is, can I call her name? Letitia. She told me, well, would it ease you if you can have a phone call? I told her yes. I spoke to her, and I explained to my daughter a little, she was like 7 years, 8 years, but I explained to her, I'm here to help myself so I can help you. And to tell you the truth, Marina changed my life so much. I have become a total different person. I learned how to take care of myself, how to treat others, how to, you know how to basically say it. It gets emotional when I still speak about it, but things I didn't know when I did growing up, things that my mom should actually teach a child, I learned everything I had to learn at Marina. I learned what my disease was about, what was causing my disease, what pains, what issues I was having, what was really the cause of my addiction. And I always thought I was just drinking because I liked drinking. That wasn't it. I had access to counselors, I had access to psychiatrists. I had, yes. Well, I didn't really like art, but I had that too to calm my ears. But one thing and I actually have a job in the hotel where alcohol is frequent. Yes. But I know today I have to say no. And one thing about Marina taught me, to trust. I never trusted anyone to let anybody know I'm an alcoholic. So sometimes I at work and they have girls I trusted, and before this, sometimes it would, like Christmas time, they asked, Vicky, come for this drink. And before I could have said, my friend was like, no, she don't drink. So all that comes in. But one of the things I still have problems with is my anger. Yes, it's going to take time. But I think the best thing is to be more out there. Because even since I've been out, I haven't seen it over the TV or anywhere like that. You understand? And I have a lot of people that just be asking me about it. Sometimes I explain to people at work what it's about. And they tell me, wow, that's amazing to have a place like that. Because most people only know about Verdun. Nobody knows really about Marina for women. You understand? And I think if we was more aware of there, more women would come forward. I know sometimes we have the difficulties of first we try thinking about our kids, but like one of my counselors always said, and I believe that we cannot help our children if we can't help ourselves. I owe a lot of my gratitude to Marina, to every counselor I have met there, Alison, everybody. It was amazing. I will tell you, God bless, and I owe everything to Marina. Thank you very much.
Vicky, it was interesting that you said about the police had to hold you. Do you think without that legal part, do you think you would have found yourself at a psychiatric hospital?
No. Because, well, I usually just drink, get into trouble, go home. But somehow, like, inside I learned that it's a progressive disease. So since it was progressing, things got worse and worse and worse. So I ended up that time getting, people didn't see me.
On another note as well, you mentioned about your child. At the time when you were at Marina House, what provisions had been made for your child? Where was your child at that time?
Oh, she was with a family member of mine, but she was giving me difficulties with the little girl. And she didn't want me to see the little girl, but she always, well, it was a difficult time because her idea was that I would go back drinking, and when I go to visit the child, she would tell the child to go inside. A lot of different issues, but with the help of the social worker from Marina, and we went to child care board, and they helped me with the process and the steps of getting my daughter back. And I did get my daughter back. She's with me for over a year and 6 months.
Thank you so much, Vicky. I'm just too emotional. You are a walking miracle. We appreciate you so much.
Thank you so much. And we continue to extend the best to you one day at a time. At this time, we invite questions in relation to the presentation, and we will open the mic to persons in the room and field questions coming from our online platform as well.
Can you hear me now?
Yes, great.
All right, so good evening again. Laura, excellent work. Vicky, thank you so much for sharing. I don't know you, and I was there welling up and being like, don't cry, Chantal, don't be a wuss in here. So thank you so much for sharing so openly and honestly. And actually, something that you said fed into a question that I had noted prior for Laura. So your study dealt with people who are already in treatment. However, is there any information about why those people entered treatment? What was the catalyst for them entering? Is it simply that the barriers were lifted, or was there something else that provoked it? In Vicky's situation, it was that, well, she was held and she was directed there. But what were the reasons that these women accessed treatment as opposed to others who haven't?
So that's a really great question. And it really comes down to individual differences. So for everyone, the reason will be different. We had, one woman spoke about the fact that after a while, she became concerned about her family image because she was embarrassing her family. So I think that was the trigger for her. There also was another lady there who at the time had just had a baby. So she was more concerned about the child, so making sure that she puts herself in good stead to look after the child and make sure it has a bright future. So those are two different rationales of how they got there. So it really shows, individual pathways to coming into treatment. But again, as you said, some may have eventually had the barriers lifted. So if we think about the example of the lady who said she went to her boss for help, it may have taken them 8 months, but eventually they were able to help her find a way to go because she didn't know where to turn. So that then would have been one barrier that was lifted for her, not knowing what treatment services were out there. Yeah, no problem.
So, Vicky, I want to thank you for being as brave as you are. Now, salvation comes after struggle. right? Nobody is saved from anything unless they're going through something that requires salvation. And the church, for example, is based upon that. It's based upon testimonies of persons who come forward and tell their story and how they found the impetus to change or the strength to carry on. And we often applaud those persons in church. Usually it's a financial struggle or something, right? And they found the strength to carry on. We often go out and highlight our heroes. When people say, you know, I wanted to be an athlete and I couldn't get sponsorship and I had to do this, I had to do that. And then we highlight them for their determination and persisting. But very seldom do we actually get the testimony from persons who've hit rock bottom because of substance abuse and who are prepared to say it. And I do think we need to find a way to encourage more of that, because the longer we keep it hidden, the more we acknowledge it or perpetuate the idea that it is something to be hidden, as opposed to be something to be acknowledged and dealt with, something to be acknowledged and treated, and the success of which we should celebrate in the same way we celebrate anybody else who's made a tremendous achievement. So I want you to keep telling your story, because you may tell your story 100 times and save one. But if you save that one, then it was worth it. And I want to encourage the NCS. I keep saying we need to find practical examples of success stories. Persons who are not, this person was just like me, and or worse. And if they can be saved, and if they can turn around, and if they can be clean, then I can be clean too. So I commend you and I congratulate you, because this is nothing short of out and out total bravery. You're one of those heroes who can inspire other people. And just every time you feel down, just remember I have overcome, and I plan to help somebody else overcome. That's all. Thank you.
Right. Jonathan, you're with the other research officer. This is just an observation that I think that the country needs to take very seriously. We know the issues pertaining to substance abuse are very complex, and they are linked to a number of social related issues. That brings me to the suggestion for our minister to put a plug in to those programs and initiatives that are promoted by the government. I'm speaking particularly the One Family program, the National Peace program, with many initiatives that link or try to reintegrate persons back into the society that they can live productive lives. For instance, what we saw today. Now, it just tells us that drug use could be critical to improving lives. And we are not a mistaken belief that the country, some aspects of our country are linked to the heavy use of drugs. Examples earlier with the alerts that were issued by the minister that there's the potential to use some very dangerous drugs as well. And all the debilitating effect on not only our young people, but the entire population. We also have from previous research that would have indicated that persons, and this research as well, would have showed that persons are hesitant to come forward if they have a substance abuse problem. So I'm just saying that, put a plug for the NCSA to become more involved with those essential programs that are being pushed by the government, that I'm hoping that the issue of
So good evening, everybody. If I thank you later, I will say what I have to say to you, Vicky, but just to reiterate what the minister said, and thank you. You do not even begin to understand how brave. Jonathan, I hope I'm not speaking ahead of the minister. Those initiatives that you mentioned, I think we just collaborated with the ministry, and CSA just collaborated with the ministry, and so the ministry, on the advice of the minister, had already selected a representative, a senior government representative, to attend a conference in which he spoke about those same initiatives as an alternative to drug use and so on. So I am hoping that out of that collaboration that we can see some growth. That representative should be back on island by now, but I do know he spoke to alternative development. And so where we don't have crop substitution, he, I am sure, represented the island well and spoke to the peace program and other things that we do have in place. So that is something that I'm looking forward to as we move forward. And as I said, I hope I'm not speaking ahead of the minister in that regard. But yes, your suggestion has already been taken on board by minister.
Thank you so much, Laura, for that research paper, and a lot of things I was nodding at. Because the need is great. There are females who are definitely battling the disease of addiction, hence why Marina was opened in 2015. It was in direct to people crying out, and we only had a male facility. Since that time on, we have had very small numbers coming in, right? And some of those barriers you definitely highlighted. One of the things I'm very aware of is with regards to the children. And that brings in so many, requires more resources, looking at it from a legal perspective, etc. And it's true, for us, a lot of the things that we have is not based on a legal agreement, but more of relationships that we have with the Child Care Board. And some persons aren't as fortunate as Vicky to have that support system. And you would have even alluded to where you did say actually that some persons do have that support system, but then they view the person going into treatment with suspicion. And a lot of your recommendations we have done, because what's one of the key things is those treatment outcomes. We can speak till we can speak, we can put them in a beautiful place residentially, but what happens afterwards? And you would know that research does show that you have to keep in contact with clients for at least 5 years. So I always say that once a client comes into treatment, their client, I said, you're going to get tired of my face because I'm going to pop up, turn up, etc. And it's so important to build that relationship, especially for females. Up until recently, I would have had a conversation with our continuing care coordinator, and we were talking about women and how, in terms of building that relationship and continuously being able to build that relationship, because women tend to finish Marina and then kind of drop out and don't come to continuing care. And then when they go to the 12-step programs, which NA and AA are excellent, but they're male-dominated. So some of the women can feel very intimidated, and obviously using together and probably having some history amongst some of those people who are also in that group can also be very traumatic to them. So as the minister said, I'm very impressed at always looking at recommendations, and you know that you have the house as we continue to collaborate with the NCSA, but phenomenal work.
But we will continue to collaborate as we move forward to certainly reduce and eliminate these barriers to treatment. And of course, all wonderful things don't always have to come to an end. We are about to suspend this session momentarily, but in the meantime, it is important to act all who would have made today possible and to extend thanks. our magnanimous for closing remarks.
So good evening, everybody. Good evening, everybody. Minister, thank you so much. For our online audience, thank you so much. Vicky, I have no words. I am sincere to describe what you just did. I cannot underscore what Minister said. Yes, Minister, yes, we have to encourage, but also with the encouragement, we have to provide support for persons like yourself who come forward. And after coming forward, you still have to go back into your workplace. You meet people that did not know before, and so we wish to provide that support for you. So Alison, with the chair next to you, hello chair. I hope I'm not speaking out of turn. The NCSA stands ready to provide any support that we can for you, Vicky, as you continue to spread your word, to grow on the path to recovery. And I just want to say to anybody who's listening that we often sometimes think that recovery is a straight line. It is not sometimes a straight line. I see the pride that Alison has when she spoke about when she first met you, because Alison is a hard taskmaster. This I know. So I just want to reiterate our support for you as you move forward. Chairman, thank you so much for giving the NCSA all the support that you give us. I know sometimes we give you a hard time, but you always rise to the occasion. So thank you so very much. Laura, absolutely wonderful presentation. Absolutely wonderful. I must say that I heard it before, but I sat there riveted again today. It had something extra. It held us all. As Minister said, people were nodding, and so thank you so much. It was a small sample, but you did it as if you had interviewed 1,000 people. Thank you for the passion that you put into that. And again, with Chairman's support, some of those recommendations welcome us in, and we stand ready to provide assistance to those within my hearing, to those workplaces who have not yet reached out, but who are now interested in crafting a substance abuse policy for their workplace. Your call to use the primary care setting, along with the recommendation to implement the integrated treatment, requires, to my mind, a boldness of breaking away from the status quo, so that we can move this business of substance abuse from the criminal justice system and bring it into formal education. So again, I do not want to belabor this evening. I think we are all primed. We are all ready to go, Laura. Thank everybody, those who I may not have mentioned by name, but those who work hard in the background, as usual. I know Deputy Manager, this was his sort of, he had oversight, but he said, it's a ladies' thing, so let the ladies be on stage today. So we are on stage, and we have put you men in the shade, well, Minister, excuse me. Right, but no, thank you again. Thank you, everybody, for all the hard work. Thank you, Laura. I really make a commitment to follow through on this bit of research, and let us see where it leads. Thank you again, Vicky. Thank you so much.
Thank you all, and at this point, we wish to adjourn this evening's proceedings. Do have a good and safe travel.